So my name's Jane Pulfreman and I'm the Nurse Unit Manager for COVID at Home Plus. We provide a service to Tasmanians for those with COVID or other respiratory illness. It's a virtual service and we are here to provide 24/7 support to any patient enrolled over a 7-day period, along with monitoring of patients' observations also. So the motivation really, as the name implies, came out of the pandemic to help respond to COVID, and it was really set up because Tasmania were going to open their borders and allow people to travel and people to come into the state. And so in order to prepare for that, this initiative was started to be able to provide additional support to those people who then might end up with COVID. I think given that there was such a tight deadline, so we had to be operational for the borders to open, that put a lot of pressure on getting the service up and running, and largely probably more around workforce. So being able to have the workforce we needed to be able to address the public's need and be able to provide the service that we set out to achieve. I guess the original modelling showed a really kind of steady increase in case numbers within Tasmania. However, the borders opened and very quickly case numbers jumped through the roof, and so we needed to adapt and really support wherever we could. So, changing models of care, onboarding staff at a very rapid rate was required. Another challenge was adapting to new computer-based programs. The clinicians have come from an area where a lot of these systems we were utilising were not previously used, so being able to rapidly upskill staff in utilising that software so that we could perform and provide virtual care, as well as, I guess, clinicians adapting to the virtual model. Staff had all come to us from areas where they're face-to-face with a patient, so being able to adapt that kind of care to a virtual model had some challenges initially. But it's been a really great experience, I think, and we definitely have achieved what we set out to achieve. So I think our program has been quite novel. Sending out monitoring kits to patients to undertake their observations every day has been a very different model of care and something we hadn't had experience with before. So I think understanding whether patients would be prepared to utilise technology and to engage with our service was kind of an unknown. Once we started to receive that feedback, which we got regularly, we can check on a daily basis to see what feedback has come in, has really, I guess, given us confidence that what we're doing does work, and that patients are not only accepting of a different model of care, but I think the positive feedback really overwhelmingly says that this kind of model of care could be used for so many other cohorts of patients. So we have a monthly operational meeting as well as monthly nursing leadership meetings. At this time, we discuss the results from the InSync surveys, and we kind of discuss what quality improvement activities there are potential within that. Good example, I would say, is fairly recently, we implemented a day 4 phone call. So we'd noticed steadily throughout the program that feedback was often that we initially provided really excellent information. If we needed to engage with the person because something was up with their observations and we needed to intervene, then we were in touch with them. But for those patients who remained healthy throughout the program and didn't call us for anything, we often wouldn't have another touch point with them. So that feedback really resonated with us, and we looked at what we could do to combat that. So we implemented a day 4 phone call. So all patients who aren't getting regular contact from us, we will contact them, assess their symptoms, see where they're at, and provide some discharge planning as well. And feedback has been really positive around that. I think being flexible and adaptable with your model of care is really important. We set out with fairly firm expectations of how we would run this service and what was required of a patient. And as we've gone on, we've seen that that doesn't work for all. So, sending a monitoring kit to someone who may not be really comfortable with technology isn't always going to work the way you planned, and not being able to find ways to accommodate those patients would be silly. So we've implemented other strategies. For instance, we'll call the patient and if they are able to utilise the technology, we will go through it with them and each day do their observations with them. Alternatively, some people just don't want to engage with technology at all, and in which case we'll contact them to check in with them, and that's also fine and shouldn't be a barrier to providing a service. I think the difference of COVID at Home Plus stems from the fact that we are fully virtual and undertake monitoring. So a lot of telehealth services might be a phone-based service, or they might also have video and audio. We undertake video calls with patients as required through the devices that we send out to patients, and we also monitor their observations. So each day a patient will get notified to undertake their observations, and we check their temperature, their pulse and their heart rate, and then based off those results we can then further triage their care, whether it be we can continue to monitor them as is, or we need to intervene and get medical attention, or even escalate up to the health service for an ambulance or into emergency. Yeah, so I guess we've already adapted our model of care to include all respiratory illness. So when we first started, we were COVID-19 only, and then in order to support the winter strategy and the flu season, we also took on all respiratory illness. So someone can refer in with anything, or just even respiratory symptoms without any kind of diagnosis. I think what we've proven is that patients like this model of care. We can efficiently deliver this model of care, and I think there's lots of scope for what more we can do. And we've certainly been speaking with other jurisdictions around what kind of virtual care is offered around the country, and how we could then expand what we do to support more people in the community. I think too often, healthcare has always been to, it's the ease of the clinician, and I think as people become more tech savvy and are more in control of their own health, they're now, looking at why is that model accepted? Why do I have to go and sit in a waiting room for 3 hours? If that's not necessary to receive healthcare. So I think patient demand is going to slowly require more of the health service, and hopefully we can respond.